A to E assessment is not just a checklist. Each step is a piece of clinical reasoning, not just a box to tick. What you find should change what you do next. A, for airway. Confirm the airway is patent and protected before assessing anything else. What to look for. Check it's patent. Look, listen and feel for any added sounds or anything that feels unusual. Check the ET tube, how many centimetres it is at the lips, or the tracheostomy position and the cuff pressure, making sure that it's within the green for cuff pressure. Secretions, what is the colour, the volume, the consistency, any signs of obstruction, particularly in awake patients such as stridor or seesaw breathing. Remember that airway loss is immediately life-threatening. You must treat this before you move on. Cuff pressure changes can signal tube migration or an air leak, meaning the patient does not get in the pressure or the ventilation required. Secretion changes may flag an infection or fluid overload, particularly if it's pink and frothy. Never proceed to B if the airway is compromised. B for breathing. Look beyond the numbers to how hard the patient is working to breathe. Assess the respiratory rate, the oxygen saturations, and the work of breathing. The chest movement, is it symmetrical? Listen to the patient's lungs if you're trained to do so. Listen for any added sounds, any wheeze or rhonchi. Check the ventilator mode, the settings, and the waveforms. You can tell lung compliance when you've been doing it for a while. Blood gases and capnography trends are also useful. Why it matters. Trends matter more than a single reading. Ventilator desynchrony can signal pain, agitation, or a new problem. Titrate oxygen to target saturations not out of habit. A falling oxygen saturation despite a rising oxygen requirement needs urgent escalation. C for circulation. Remember this is perfusion, not just blood pressure. It tells you how well the organs are coping. What to assess. Heart rate, blood pressure, very importantly mean arterial pressure. Rhythm, capillary refill, both peripheral and central, skin temperature, fluid balance, and cumulative fluid balance from the previous 24 hours. Urine output, making sure that it's 0.5 mils per kilo per hour. How much vasoactive drugs the patient's on, so noradrenaline, dobutamine, and the status of the lines. So how long the line's been in, does it look fine? Are the lines in date? Are the infusion lines correct? And is the strength drawn up properly? Remember that MAP targets guide organ perfusion, not just the number alone. So you're looking there for lactate in particular and making sure the lactate is less than 2. Check for cold, mottled skin. This can precede a drop in blood pressure. Fluid balance and urine output reflect renal perfusion. Adjust drugs and fluids to the trend. Don't chase just one value. D for disability. Neurological status changes fast and can override other priorities. What to assess? GCS or AVCAPU. Remembering new confusion. Pupil size and reaction, sedation scores that we use commonly in ITU would be RAS or the Richmond Agitation Sedation Score, and in awake patients, pain score. Obviously, don't forget blood glucose here, and any new focal neurology needs to be escalated immediately. Remember, a fall in GCS takes priority over routine tasks. Under or over sedation both delay recovery. Hypoglycemia can mimic neurological deterioration. Compare against the patient's baseline, not just for today. And remember, when you're taking handover from a previous nurse, check pupils together. And finally, E for exposure. A full and dignified review closes the loop and often reveals what earlier stages have missed. What to assess. full skin inspection and core temperature, particularly important in sepsis and neurological injury. Check wounds, drains, dressings, pressure areas, lines and catheters, ensure sight, patency, necessity. Maintain dignity and minimize heat loss. Please keep your patients covered. Why this matters. Pressure injuries and line infections start unnoticed. Fever and hypothermia both point to physiological stress. Every invasive device is a risk that needs daily justification. New findings here should prompt reassessment from A again, and always escalate if you're worried.